So we try to cover two things that it may come as a long question during your clinical examination also. So we will try to cover the both aspect, one the clinical aspect and the theoretical aspect. So jaundice, there is difference between the jaundice and hyperbilirubinemia. That is, the jaundice also many times called as icterus. When we mention in the clinical examination, the icterus is present or not. So jaundice means this yellowish discoloration of the skin or the body. That may include the sclera and the generalized skin. So this is the yellowish discoloration of the skin, that is called the jaundice, but that doesn't mean that it is due to hyperbilirubinemia. Okay, so there is a difference between the jaundice and hyperbilirubinemia. So we will see the different aspect of the jaundice and the hyperbilirubinemia on the subsequent slides. So jaundice, by definition, it is the yellowish discoloration or pigmentation of the skin and the or this conjunctival membrane resulting from the high level of bilirubin in the blood, or it is yellowish discoloration of the skin, sclera or mucous membrane due to hyperbilirubinemia, and it's also called as icterus. Okay, but the tissue deposition of the bilirubin occurs only in the presence of serum hyperbilirubinemia. In normal condition, we have bilirubin in our blood, but it doesn't cause yellowish discoloration of the skin. It's only happen when there is hyperbilirubinemia, and we will discuss later on how much hyperbilirubinemia is required to cause jaundice. And it is one of the manifestation of liver disease, or less often a disorder of the blood, that is the hemolytic disorder, they we also call as hemolytic anemia, or itself a disorder of bilirubin metabolism, where either conjugation doesn't take place in the proper way, or the bilirubin is not taken by the hepatocytes in the proper way, or the bilirubin disposal from the body is impaired. That can lead to hyperbilirubinemia. So when we have been asked to examine for the jaundice, so we have to remember some sites that has to be examined during the examination of icterus. So always examine the patient in the natural daylight, as it is difficult to detect mild jaundice in fluorescence lighting, like this tube light we having indoor. So that may cause some problem in detecting mild amount of the jaundice, or you are using this orange light or something. So it is become very difficult to recognize jaundice in presence of this artificial light. So it is always advisable to examine the patient in natural daylight. Okay, and while examining a patient for the icterus, remember one more important thing is that never throw light on the eyes to examine for the jaundice. So during the examination of oral cavity, we put the torch light, or nowadays with the help of the mobile light also we sometimes examine the oral cavity. But for the examination of jaundice, never throw light on the eye. So these things has been noticed, especially when you will face for the long case or clinical examination, the bedside clinics. Then coming to the site of the examination, the first site you have to examine is the sclera, that is called the scleral icterus. Then the underneath of the tongue, then the soft palate, then the palm and sole, then generalized body skin. So remember this sequence also. Okay, so you cannot detect a jaundice if it is mild on the general body skin or palm or the sole. So the first area where it will be appear is the conjunctival membrane, and it will be examined as a scleral icterus. So for examination of the scleral icterus, you have to retract the upper eyelid in upward direction and ask the patients to look in downward direction, or to look at the tip of the nose. So that will bring down the cornea in downward direction, and it will, just you can see from the picture, you will have a better access to the upper part of the sclera. And the upper part of the sclera that is not usually becomes dirty. This exposed part of the sclera maybe becomes dirty, and you will have this wrong impression of yellowish discoloration of the sclera. So it is how we examine a patient for the scleral icterus. So retract the upper eyelid in upward direction. Ask the patients to look in downward direction or toward the tip of the nose. Then notice for any yellowish discoloration of the upper part of the sclera. And why is the sclera is very specific for the jaundice? The reason is that it contains high elastin in the sclera, and elastin has a great affinity to the bilirubin. So the bilirubin having the high affinity to the scleral elements like the elastin, because of that this sclera will be the first site where you can detect the jaundice even in the mild cases. And remember one more thing, that the presence of the scleral icterus indicate that the serum bilirubin is at least 51 micromole per liter. That in Indian standard it comes as 3 milligram per deciliter. So to appear in the sclera or to appear as a scleral icterus, the bilirubin level must go beyond 3 milligram per deciliter. And at the same time, the sclera is the first area to be affected by the hyperbilirubinemia. So below 3, patients may have the hyperbilirubinemia because the normal bilirubin is up to 1 milligram per kg body, up to 1 milligram per deciliter. So between 1 to 3, there will be hyperbilirubinemia. It is not the normal bilirubin, but clinically will not get the sign of jaundice. So that's we call it as latent icterus or subclinical jaundice. Okay, subclinical hyperbilirubinemia. Sorry. Okay, because here the bilirubin will be high, there will be hyperbilirubinemia, but clinically not detectable on examination. So, and this level is from 1 to 3 milligrams. Usually at 3 milligram, you can detect the scleral icterus. Now the second is, the site is the undersurface of the tongue. So you can see here how we examine for the icterus on the undersurface of the tongues. Ask the patients to open his or her mouth and roll up the tongues in upward direction. Examine the undersurface of the tongue, that is the sublingual mucosa, and also the palate. There is a hard palate and soft palate. Remember, it is very difficult to examine the icterus on the dorsum of the tongues because most of the times it may be the coated, or because of the food particle or dry tongues, you will not able to assess that. But the undersurface of the tongues, it is quite easy to detect the hyperbilirubinemia or detect the icterus. But at the same time, it will not be that easy to detect the icterus in hard palate or the soft palate. So these are the site for the examination of icterus in the head region, head and neck region. That is the first the sclera, then the undersurface of the tongue, then the hard palate, then soft palate, then comes the palm and sole. So when the bilirubinemia goes on increasing or it goes beyond 5, then you may start getting the hyperbilirubinemia of the palm and sole also. So once you get the pigmentation over the palm and sole, that means the bilirubin is quite high, or the hyperbilirubinemia is quite severe. It is not the mild. And usually in case of hemolytic jaundice, you will not get hyperpigmentation of the sole and palm because there the hyperbilirubinemia is not beyond 5 milligram per deciliter. Okay, so if you are getting the hyperbilirubinemia that affects the palm and sole, that means it is not a hemolytic jaundice, you are dealing with something else. Then the generalized body skin. So once the bilirubin is too high, then you may get generalized discoloration or generalized yellowish coloration of the whole body. Then many times over the skin you will may get the scratch mark because hyperbilirubinemia obstructive jaundice causes this pruritus, and this category of patient or this type of patients have a tendency to scratch the body. So the scratch mark is quite common in case of hyperbilirubinemia. Now coming to the states of the jaundice. So you might have heard this lemon yellow tinge or orange color or greenish yellow. So here I try to just give an example of this lemon yellow. Lemon yellow, you know only what is lemon yellow. So it represents usually mild jaundice, and it is usually seen in hemolytic jaundice where the usual bilirubin is less than 6 milligram per deciliter. So remember one thing, it is if it is only hemolytic jaundice, the bilirubin levels usually do not go beyond 5 milligram per deciliter or 6 milligram per deciliter. So in case of hemolytic jaundice, most of the times you will get mild jaundice. Then the arrow orange yellow color, it is typically you will get in hepatocellular jaundice. Usually it is a deep jaundice with mixed conjugated and unconjugated hyperbilirubinemia. Then green is yellow. And when a person having jaundice for the long period of the times, especially obstructive jaundice, CBD stone, or any malignancy involving the hepatobiliary system, so you may get this now too high bilirubin, and that bilirubin present there in the body for the longer period of the times. And once the bilirubin present in the body for the longer period of the times, this exposed area, it will get oxidized with the contact with the air. This long-standing jaundice gives rise to greenish yellowish tints due to conversion of bilirubins to biliverdin, and this greenish tinge is because of the biliverdin. So remember, if it is lemon yellow, you will get in the mild jaundice. Orange, it represents deep jaundice, and the greenish yellows usually represents long standing jaundice, and that also represent the deep jaundice. Then if you face or you got a case having this yellowish discoloration of skin, remember that all the yellowish discoloration of the skin doesn't mean the patient is having jaundice, means having hyperbilirubinemia. So not all yellowing of the skin is jaundice. Jaundice means yellowish discoloration of the skin because of hyperbilirubinemia. So the causes of yellowish discoloration of skin are hyperbilirubinemia. This is a classical jaundice. Then keratinoderma, when the people takes too much of the keratin, they can have this yellowish or orange discoloration of the skin. Then we will later on discuss how to differentiate the keratoderma from the hyperbilirubinemia. Then some drugs may causes yellowish discoloration of the skin, and the common one is quinacrine. This drug is now not commonly used, but previously it was used for the malaria. Then the excessive exposure to phenol also sometimes cause yellowish discoloration of the skin. So keratinoderma is a yellowish color imparted to the skin of healthy individual. They do not have any liver problems. They are healthy individual who ingest excessive amount of vegetable or fruit that contains keratin, such as carrot, then leafy vegetable, squash, then peach and orange. And classically, these patients do not have yellowish discoloration of the sclera. In jaundice, you will get yellowish discoloration of the sclera, and there is uniform distribution of the discoloration all over the body. Whereas in keratoderma, the pigment is concentrated on the palm, sole, forehead, nasolabial fold. And keratinoderma can be distinguished from the jaundice by sparing of the sclera. So classically, in jaundice, the first site to be involved is the sclera, but keratoderma, classically they do not involve the sclera. So sclera will remain white. So you can see in the picture, this sclera is remain white, but rest, this palm, face, forehead, they have yellowish discoloration. Now latent jaundice. So normal serum bilirubin concentration are between 0.2 to 0.9 milligram per deciliter in 95% of the normal individual. Okay, so some people may have more than that, little bit, but usually 95% of the normal individual, they have the bilirubin 0.2 to 0.9 milligram per deciliter. So, and clinically, jaundice injectable fan, the serum bilirubin is at least 3 milligram per deciliter. So serum bilirubin between 1 milligrams to 3 milligrams is though high, not detectable on clinical examination. That's why we call it as latent jaundice. Okay, so remember the definition of latent jaundice. So in brief, something about the bilirubin productions, from where the bilirubin comes. During the maybe the long case examiner may ask you about little bit about the bilirubin metabolism. So bilirubin is a tetrapyrrole pigment, is a breakdown product of heme. Heme is a constituent of hemoglobin. So total bilirubin production in body each day is around 4 milligram per kg. The source of bilirubins are breakdown of hemoglobin in the senescent RBC, then prematurely destroyed erythroid cell in the bone marrow, then turnover of hemopoietin or hemoprotein like myoglobin and cytochromes. And the site of bilirubin production is reticuloendothelial cell, primarily the spleen and the liver. So in hemolytic anemia, it's obvious that this tissue have to work hard because this is the site for the damage of RBC, and thus you may get enlargement of the hepatocyte, enlargement of liver and spleen in case of hemolytic anemia. So the source of bilirubin is prematurely destroyed erythroid cells in the bone marrow, breakdown of hemoglobin in the senescent RBC. They contribute around 80 to 85% of the total bilirubin. Okay, then some from the myoglobin, then the hemoprotein, cytochrome. So the total bilirubin production per day is 4 milligram per kg per day. So then the bilirubin transportation and conjugation, remember, because lots of congenital diseases that affect the bilirubin metabolism can lead to hyperbilirubinemia. So bilirubin from the endothelial cells are virtually insoluble. To become soluble, they have to be bound non-covalent to the albumin. Then it is conjugated in the unconjugated bilirubin bound to albumin is transported to the liver, and the liver, after entering the hepatocyte in endoplasmic reticulum, the bilirubin is made aqueous soluble by conjugation to glucuronic acid and aryl bilirubin, monoglucuronide and diclonide. And these conjugated bilirubins are water soluble. Remember, these conjugated bilirubins are water soluble. And it is important when we will differentiate the bilirubin hyperbilirubinemia into conjugated and unconjugated hyperbilirubinemia. And these conjugated bilirubin excreted in the bile drain into the duodenum and pass unchanged through the proximal small bowel. So, and then it is this unconjugated bilirubin excreted in the bile goes to the duodenum and pass unchanged through the small bowel. Then when the conjugated bilirubin reach the distal ileum and colon, it hydrolyzes to unconjugated bilirubin by bacterial beta-glucuronidase, and the unconjugated bilirubin from the gut reduced by the normal gut bacteria to form a group of colorless tetraperol called the urobilinogen and other products. And almost 80 to 90% of these products are excreted in the feces, either unchanged or oxidized to the urobilin. Okay, and the remaining 10% are goes back to the entrohepatic circulation and entrohepatic recycling. So if you see this picture, you can see here, so almost this in the distal ileum and the colon, conjugated bilirubin hydrolyzed to unconjugated bilirubin by bacteria beta-glucuronidase, and this unconjugated bilirubin is reduced by normal gut bacteria to form a group of colorless tetraperol called urobilinogen and other products. And 80 to 90% of the urobilinogen is excreted in urine, either unchanged or oxidized to orange derivatives called urobilin. And this urobilin gives color to the normal feces. Okay, and a small amount, usually less than 3 milligram per deciliter of urobilin escape hepatic uptake and filter across the renal glomeruli and is excreted in the urine as urobilinogen. Okay, and around 10 to 20% of the urobilinogen undergo entrohepatic cycling. This diagram is important because when we assess or a person with this hyperbilirubinemia, these all knowledge are needed to differentiate between them as this unconjugated hyperbilirubinemia, conjugated hyperbilirubinemia, or the mixed type. Where is the problem? So if you classify the jaundice, we can classify in two ways. One is clinically, one is called the hemolytic jaundice, obstructive jaundice, and hepatocellular jaundice. Hemolytic jaundice means there is destruction of the RBC that leads to excessive production of the bilirubin. And the obstructive jaundice can further classify into intrahepatic and extrahepatic. Obstruction may be in the extrahepatic like the common bile duct, intrahepatic like inside the liver, small intrahepatic biliary duct, or the hepatocellular jaundice when there is damage to the hepatocyte. Then on the basis of the proportion of the fractionated bilirubin, we can divide into direct hyperbilirubinemia and indirect hyperbilirubinemia. Indirect hyperbilirubinemia means when the total proportion of the direct bilirubin is more than 15%. Okay, and indirect hyperbilirubinemia means when the direct bilirubin is less than 15%. So all causes of obstructive jaundice fall under direct hyperbilirubinemia. Then hepatocellular causes like then the congenital like Dubin-Johnson and the Rotor syndromes, they falls in direct hyperbilirubinemia. Indirect causes, all causes of hemolytic jaundice. Then the congenital causes like Crigler-Najjar type 1 and type 2 syndrome, then the Gilbert syndrome. So you have to remember these names. It may be asked in the examination. So in hemolytic jaundice, what happens? You know only the normal metabolism of the bilirubin. So here what happened? There is excess production of the bilirubin, and so it get conjugated normally, excreted in the long intestine, but amount of the bilirubin in circulation with the albumin is increased. Okay, and bilirubin in circulation combined with albumin is not filterable at the glomerulus, and that ultimately leads to hyperbilirubinemia. So in unconjugated in hemolytic jaundice, all the metabolism is okay, but it overwhelms the capacity of the body to handle the excessive amount of the bilirubin, and that is reflected back as increased amount of unconjugated bilirubin in the circulation, and that are bound to albumin, and these albumin bonds are not excreted normally in urine, so that's why we have hyperbilirubinemia. So the causes of hemolytic jaundice are, how will differentiate clinically? They have achloururic urine means no bilirubinemia. Urine will be of normal color. Stool will be of normal color. There will be anemia due to hemolysis. You will get splenomegaly or hepatomegaly. Jaundice is usually mild. There is lemon color jaundice, and there will be high incidence of pigment stone formations like gallstone with increased likelihood of polydocholithiasis. Reticulocytosis will be there because of hemolysis, and liver enzymes are normal. So there is no problem in the liver. Okay, and as it is unconjugated hyperbilirubinemia, urine color will be normal. Stool color will be also normal because normally the bilirubin will be passes to the stool also. Then the causes of hemolytic jaundice are the inheritance like thalassemia, sickle cell anemia, spherocytosis, deficiency of red cell enzymes like pyruvate kinase deficiency or glucose G6PD activity deficiency. Then the acquired causes are microangiopathic hemolytic anemia like hemolytic uremic syndrome, paroxysmal nocturnal hemoglobinuria, spur cell anemia, immune hemolysis, parasitic infection like malaria and babesiosis. Then the ineffective erythropoiesis like cobalamin, folate or iron deficiency, and some conditions like when we have somewhere big hematoma, then this blood is absorbed. So the absorption of the hematoma or massive blood transfusions may causes hyperbilirubinemia. Then the obstructive jaundice, what happens? There is obstruction in the drainage of bile, and there will be no drainage of the bile in the duodenum. So there will be conjugated hyperbilirubinemia. Liver is functioning normally, so there will be increased amount of conjugated bilirubin. Okay, so conjugated bilirubin is blocked, excretion is blocked. So impaired bile excretion into the duodenum, increase in the circulation of conjugated bilirubin. And you know that conjugated bilirubin is water soluble, so there will be increased conjugated bilirubin freely filterable at the glomerular, causing bilirubinuria, and you will have dark urine. At the same time, as this normal bilirubin is not excreted in the large intestine, so you will get pale or clay colored stool, and as bilirubin is needed, bile acid is needed for the fat absorption, there will be poor fat absorption from this. So you will get the fat particles in the stool, increased fat, then the stool color will be pale or clay color. So clinical presentation will be urine dark yellow or mustard color due to hyperbilirubinemia. Stool is pale or yellow color, poor fat absorptions that can lead to steatorrhea due to absence of bile in intestine. The jaundice will be deep with grayish yellow in color. There will be generalized pruritus because of deposition of the bile salt. Patient will have sinus bradycardia. Other problems may be bleeding problems, osteomalacia. Then liver enzyme will be slightly will be high, like AST, ALT will be high, alkaline phosphatase will be very high because of obstruction. Now the causes of obstructive jaundice may be intrahepatic or the extrahepatic. So intrahepatic causes are the cholestasis viral hepatitis like hepatitis B, C, A, this is viral hepatitis. Then the alcoholic hepatitis, then drug toxicity like anabolic and contraceptive steroid, chlorpromazine, erythromycin, then prochlorperazine, the primary biliary cholangitis, primary sclerosing cholangitis, vanishing bile duct syndrome like chronic rejection of the liver transplant. The other causes are congestive hepatopathy, then the cholestasis of pregnancy, veno-occlusive disorder like Budd-Chiari syndrome, graft versus host diseases, then inflammatory disease like tuberculosis, lymphoma, amyloidosis, infection, malaria, and leptospirosis. These are the causes of intrahepatic obstructions. Then the extrahepatic obstruction causes may be malignant or benign. Malignants are cholangiocarcinoma, pancreatic carcinoma, that is the head and the periampullary carcinoma, gallbladder cancer, or malignant involvement of the portohepatis lymph node. Then the benign causes are choledocholithiasis, postoperative biliary stricture, primary sclerosing cholangitis, then the chronic pancreatitis, AIDS cholangiopathy, Meniere's syndrome, parasitic disease like Escherichiasis. Then the third category is the hepatologic jaundice. Here the urine color will be the high. It behaves like a obstructive jaundice, but stool color will be normal. Jaundice will be yellow orange tinge, will have yellow orange tinge, and the amount of the conjugated bilirubin will be more than unconjugated. You will get tender hepatomegaly, may be present. Then features of hepatic failure may be present, depends upon the severity. The causes are again the hepatitis due to the virus like hepatitis A, B, C, D, E, then Epstein-Barr virus, cytomegalovirus, herpes simplex virus, then Wills disease, alcoholic hepatitis, chronic liver disease and cirrhosis, acute fatty liver of pregnancy, drugs, toxicity, the environmental toxicity, then the Wilson's disease and autoimmune hepatitis. These are the causes of hepatocellular jaundice. So once you get a case of jaundice, then how will investigators, how will proceed to investigate those patients? So you have to take the history properly. Focus must be on the medication, drug exposure, physical examinations. You have to do a thorough physical examination. Then you have to send some laboratory investigations. And these tests are the bilirubin with fractionation, ALT, AST, alkaline phosphatase, and prothrombin time and albumin. So depending upon them, if there is an isolated elevation of the bilirubin, means only the bilirubin is high, but AST, ALT, and other liver enzymes normal, that means it is not this hepatocellular jaundice. So then you have to divide it into indirect hyperbilirubinemia. If the direct bilirubin is less than 15%, and direct hyperbilirubinemia is direct bilirubin is more than 15%. Then in other category, there will be, along with hyperbilirubinemia, there will be increase in AST, ALT level, or there will be increase in transaminase level. So that can be further divided into hepatocellular category and obstructive category. In the hepatocellular category, AST, ALT elevated out of proportion to the alkaline phosphatase. And obstructive category, that is cholestatic category, alkaline phosphatase will be out of proportion of ALT and AST. So in both cases, ALT, AST will be high, but if it is obstructive, then you will get increased level of alkaline phosphatase. Here, alkaline phosphatase will be at the lower side in comparison to the AST and ALT level. So on the basis of this, you can divide it into indirect hyperbilirubinemia. If it is direct, then whether it is hepatocellular or cholestasis. So then again, isolated elevation of the bilirubin, if it is indirect hyperbilirubinemia, if direct bilirubin is less than 15%, the causes are very few, that are the hemolytic disorder. Then you will get anemia, reticulocytosis, hepatosplenomegaly. Then you have to do few tests to identify what types of hemolytic disorder is there. Then inherited conditions like Crigler-Najjar syndrome 1 and 2 and Gilbert syndrome fall in this category. And only if there is direct hyperbilirubinemia, but all liver enzymes are normal, then there are few cases only, few diseases are only that can causes this type of problems, and they are mostly inherited. And this category falls are the Dubin-Johnson syndrome and the Rotor syndrome. Then bilirubin, hyperbilirubinemia with AST, ALT, and alkaline phosphatase derangement. If it is hepatocellular, then you have to send for viral serology to rule out viral hepatitis. Or if it is normal, then you have to do toxicology screening to rule out the Wilson's disease. You have to do the ceruloplasmin. You have to find out this level of the ceruloplasmin. Then, if you suspect autoimmune hepatitis, then you have to send for antinuclear antibody, then SMA, then SPEP. And it is very easy to diagnose a case of obstructive jaundice. The things you have to do is ultrasound. You will get dilated biliary tract, and if you further investigate, then you may need CT, MRCP, or ERCP. So in this is in very short about the hyperbilirubinemia mechanism, how to do the clinical examination of case of hyperbilirubinemia, and what are the investigation, and what should be our approach to a case with hyperbilirubinemia or jaundice. Remember, jaundice may be asked as a long case in your examinations too, so that's why you should read thoroughly the jaundice and also how to do examination of a case of jaundice. So with this, I will stop here. Thank you very much.